Today I'm going to talk about motivational enhancement with goal setting. Really, I think these are tools that we can use in our patients in primary care, whether it's pain management or a lot of other settings too. I think of diabetes, I think of substance use, I think of depression, a lot of ways that we can use these tools, and it's really enhanced my practice, so I want to share some of it with you today. Next slide. So this is a evidence-based style of health behavioral change counseling. It's sort of a morph of motivational interviewing that is a little bit briefer and doesn't take quite as much training. It's been studied especially with alcohol, but there have been a lot of applications of this style of counseling to the primary care setting with a lot of positive results. The overall philosophy here is that change can only come from the patient, and that's obvious because it's behavior change, and we can't do that for the patient. And really our goal in the interaction with the patient is to enhance their motivation and their commitment to change. And there are ways that you can do that that are pretty specific and that have evidence behind them. I also find that these sort of techniques that you can use really make the primary care interaction more fun when it comes to talking about behavior change, and I do think it enhances the effectiveness. A lot of people comment that these tools are really good when you have teenagers as well. Next slide. So I'm going to talk about two steps, kind of boiling this down to two simple aspects of a clinical encounter when you're talking about behavior change counseling. One is enhancing motivation to change, and that's trying to get patients to talk in a positive way about change. So that's self-motivational statements, or change talk, as they call it in motivational interviewing, and with the goal of trying to get the patient to understand what they feel is important motivation to change, and then balancing that with the ambivalence that everyone feels about behavior change. And then the second step is developing a plan. This is kind of after you've gone through some work with the patient, or sometimes the patient just shows up and says, "Doc, I need to quit smoking." And then you're talking about a patient with the motivation in place and really wants to engage in self-management. It's kind of just talking about how to go about that kind of process from a patient-centered place. Next slide. So there are a lot of times you can practice this. I think it's an interesting contrast, this style, compared to giving advice or educating a patient. We all sort of develop our spiels about exercise or diet or adherence to medications, and we kind of feel it's kind of the theory there is that you educate the patients and they will do what you say because they now understand. But most of the behavior change issues that patients have much more to do with they kind of know the information. They don't need the education, but they just haven't worked through the ambivalence around behavior change. And so this is an effort to get, when you think about, okay, it's time to educate the patient about their alcohol for the fifth time, then maybe you could stop and pause and say maybe these other techniques could be effective. If the patient has agreed to behavior change but hasn't made changes, these techniques can help. If a patient is expressing resistance to behavior change, then it's another time to consider how to change your approach, and that really ends up being pretty much. If you take behavior change as part of your practice that you're going to be encouraging your patients to do, which I totally think is part of the primary care mission, then this comes up quite a lot. Next slide. So I'm going to talk about change talk and resistance. So the theory here is from motivational interviewing is that as I hear myself talk, I learn what I believe. So that the goal here is to have the patient, they may be talking to you in the exam room, but they're talking to themselves too, and they are learning what they believe by processing it through their own language. So change talk is the patient language that supports behavior change. Resistance is language that opposes behavior change. Most everyone has both of those feelings, both they have ambivalence, but it's been shown that if patients who express more resistance are less likely to change, and even our behaviors and some of our educational approaches, while intended well, can often promote resistance. If we say, you really need to stop drinking because your liver looks like it's in trouble, it's easy for a patient to present the other side of that story. Well, my only social life is drinking. And that's resistance talk. And we can make more of it through more confrontational style, or even, I would argue, more educational style. So motivational techniques are really an alternative to that, promoting change talk, minimizing or diffusing the resistance talk. It's not that you never want to hear it, but you want it diffused and balanced with more change talk. Next slide. So when you do get resistance from patients, and you will, because even if they want to change, they're also going to be ambivalent and have reasons why they may not want to change. You never want to be arguing. So if a patient presents that, it's the only social life I have when I drink, answer to that is not arguing, well, is it worth your liver to go for those friends, or even some kind of advice like, well, could you drink something else besides alcohol? That's again asking for potentially more resistance. Instead, trying to do a reflection. That's the best response to resistance talk. And a reflection is basically validating the patient's experience and is said as a statement. So it's so in this case, a patient saying, my only social life is alcohol. You might say, so you're worried that if you gave up alcohol, you'd lose all your friends. That might be a reflection. And the idea is to make sure that they understand that you validate what they're saying, you understand it. They may not take such a strong line as I just took. They may not think that, but at least it's opening a conversation. And the other thing about the way I said it is important. So motivational interviewing talks about having your voice go down at the end of a reflection. And I can give that same statement with my voice going up and saying, so you can't imagine so you think drinking, let's see, what did I say? So you can't imagine having a social life without drinking alcohol? That's a yes or no question. And it invites sort of an end of a conversation. So a reflection has a voice going down. You can't imagine having a social life without alcohol. And that sort of inviting more conversation. So that's an example of how you can meet resistance without arguing. It sometimes can soften the patient's resistance, open up change talk, and another way to go about that when you get a lot of resistance is to explore the pros and cons of their current behavior, asking them what are some of the good things about drinking now, or and then what are some of the less good things, so that you can, and if they've felt like you've heard them when they talk about the good things about their current behavior, they may be more likely to open up about the less good things. Next slide. So asking for change talk is pretty simple. You can just say, tell me what your concerns are about this behavior, and just inviting them to come up with something, and or tell me why you think you might need to make a change in your behavior. And then once they say something that is supportive of change, your goal in terms of enhancing change talk is to tell me more about that, or reflecting. So you're worried about this. Again, voice going down, reflection may elicit a little more change talk, or probing what else might there be that you're concerned about. And so each of these techniques just is aiming to get more change talk, which is associated with behavior change in the patient. And that's actually an intervention in itself. Next slide. So the importance scale comes from motivational interviewing and can be used in the same way. On a scale of 0 to 10, how important is it that you think it is to change your behavior? And then if they say, oh, it's a 2 out of 10, not very important on that 0 to 10 scale, you can still ask them, why is it not a 0? And that can help them identify a concern that they do have. And you can ask them to open up more about that, tell me more about that, or reflect that, or what other concerns do you have? Next slide. So I'm going to just move on to step 2. So we've talked about enhancing motivation. I've really talked mostly about change talk or self-motivational statements, some about how to respond to resistance with reflection and the importance scale. So now we're going to move on to the second part of this, which is the patient who may have some motivation to change, and how are you going to actualize that in a plan. Next slide. So when you're making this transition from trying to encourage change talk or elicit change talk to making a plan, you have to get the timing right, and you have to identify that the patient's ready for this kind of change in the topic. So some patients may, really resist behavior change, and no matter how much you get them to talk about their concerns about the behavior, they're really not ready. And some of those signs, they may be guarded or hesitant, or they may miss your appointment. That certainly happens. They could be indecisive. Or another example is maybe they're kind of coerced into behavior change. Maybe they had that big MI and now they're facing the fact they can't smoke anymore, or it doesn't have to be actual criminal justice coercion, although that does happen. But sometimes people are coerced into behavior change because they can't keep doing what they were doing, or their health will suffer too much. And if they have been coerced by circumstances, have they kind of dealt with that? Have they processed that? And have you adequately reflected that that must be a hard situation to be in? There are other patients who are ready for behavior change, and you get a lot more change talk going. They seem resolved. They're not doing so much resistance talk, and they start to imagine what it might be like for them after a behavior change. And that, I think, those are signs that it's time maybe to move towards making a plan. So you can do that by summarizing some of the conversation you've had up till now. What are the pros of behavior change, the cons of behavior change, and then saying, so where do we go from here, or what are you thinking you might want to do about it? So again, it's moving the conversation towards what they might want to do, but trying to be very open about it being a patient-centered process. Next slide. So if a patient does want to make some kind of change, say they've decided that they want to control their diabetes better, or they want to control their pain better by losing some weight, maybe that's their goal, is weight loss, and you can help them identify that, and then help them brainstorm some activities they might do to accomplish that. What ideas do you have for this? And I think it's the patient's ideas first is the principle, that if they're coming up with, if they have an idea that it might work, that's probably where it's worth spending your limited time, rather than your idea about what the best thing would be for them to do. And then trying to get that activity, just maybe it's exercise, and then try and focus that activity on what kind of exercise, how often, how long, with whom, when, all those details that might help them really start to imagine what it would be like to make a change, and get those things explicit. And then you can also consider barriers to change as a part of building a plan, so that if they identified particular times it would be hard, or particular obstacles, you may be able to do some brainstorming about how you could deal with those. Next slide. So the confidence scale is used in this aspect of planning, and try to discuss with the patient what their behavior change plan will be on a scale of 0 to 10. How confident are you that you could make this change? And if they say a 5 out of 10, then why isn't it less? Might show the patient's motivation, might show their self-efficacy in doing this, maybe the supports they have, other people, that they have who might help them, and that can be helpful to identify. And then why aren't you completely confident, or why isn't this a 10, might help you identify some of those important barriers. You don't have to use the scale necessarily to get at those things, but it's a kind of a simple way to deal with this aspect of planning for behavior change. Next slide. So when you make a plan with a patient, just reviewing it at the next visit, and I really find it's important to document what plan or how far the conversation has come. Maybe the patient has expressed a lot of resistance, willing to consider talking about it again with you, but really not ready to make a plan, versus, well, he decided that he was going to start walking 3 times a week for 20 minutes, and he's going to get support from his friend, and the barrier is that he's got to get some new shoes to do that. So you could put a few things down like that to remind you where the conversation is. The patient may not have gotten past the waiting room with that plan, but at least it's clear to the patient that you find behavior change to be an essential part of your medical care with the patient, and that's, I think, a really important message. You can spend some time renewing motivation, kind of going back to that, asking for change talk again as part of the conversation. It doesn't have to be a long thing to do that. And then patients, if patients are not doing anything or they're resisting a lot, the motivational interviewing stance is really that it's up to you what you do about this. Maybe it's too hard to change now. Maybe you can't imagine life without things the way they are, or some kind of way to express that it's free choice, that it's theirs to do and not yours. And then a lot of times we do have advice that may actually be helpful for patients if they've tried to quit smoking 6 times, and they've used the patch and they've used the gum, but they've never used other medicine, or they've never tried certain techniques. You could give some advice, but if you're going to do that within motivational interviewing, generally you want to emphasize what the patient is asking for, and ask permission if you want to give some more information. I often say some of my other patients have found some other things to be helpful. Would you like to hear about that? And then kind of at least gets the patient's buy-in on getting some new information. Next slide. So I just encourage you all to practice this a little bit. It doesn't have to be in every patient that you see, or every behavioral issue that the patient brings, because many times, especially with pain patients, there are 5 or 6 behavioral changes that they might consider making. And it's not like you're going to spend an hour going through each one and trying to come up with doing this kind of process, but it can be done pretty efficiently, and I think it emphasizes to the patient again that you care about their behavior, their self-management. So, and 2 steps, the enhancing motivation to change. We talked about change talk and asking for that, and the importance scale, and then developing a plan. How do you think you might make a change, and building a plan that's specific, that's realistic, and the confidence scale is there as a tool. So you could say to yourself before your session this afternoon, I'm going to find 1 or 2 patients. I'm going to identify some behavior change things that the patient might be willing to discuss, and I'm going to just have a 3-minute conversation with them about it. Ask for change talk. Summarize the pros and cons of behavior change for the patient. Where do you want to go from here? And just see what happens. See if it changes how the interaction goes. Next slide. So in pain care, obviously we talk a lot about physical activity, and I think this is probably one of the most common behavior change topics that I use in primary care is initiating or increasing physical activity. Coping skills are another, the kinds of menu that we talk about when we talk about CBT for chronic pain. There's all that menu of stuff that patients could do, and it's all behavior change. Reducing opioid dose, trying non-opioid medications, if they're depressed, trying some kinds of activation strategies, not just exercise, but just getting out of the house, socializing, that kind of thing, and exploring other kinds of treatment, non-medication treatment options for chronic pain. Next slide. So just a couple of resources if you're interested in this. The top two are books and are really helpful if you want to go a little deeper with this. There's lots of trainings in motivational interviewing around. And I really encourage you to use this. I think it really enhances your practice.